this university. He obtained his Bachelor of Medicine and Bachelor of Surgery degree from her College of Health Sciences in 1999. He completed his postgraduate residency training in surgery at the Obafemi Awolowo University Teaching Hospital Complex, Ile-Ife. He earned the fellowship of the West African College of Surgeons in 2008, the fellowship of the National Postgraduate Medical College of Nigeria in Surgery in 2010, the fellowship of the American College of Surgeons in 2016, and a Doctor of Medicine degree in 2023. Professor Adisa began his academic journey as Lecturer 1 in the Department of Surgery of this university in December 2008. He rose through the ranks and attained full professorship in October 2017. His contributions have profoundly impacted the surgical landscape of Obafemi Awolowo University and beyond. He pioneered laparoscopic general surgery at the Obafemi Awolowo University Teaching Hospitals Complex, adopting innovative solutions to perform both basic and advanced procedures, and establishing training frameworks that have empowered hundreds of professionals. His influence extends beyond Nigeria, having facilitated surgical advancements in many countries across West Africa and serving as an expert trainer at the IRCAD Africa Training Center in Kigali, Rwanda. With over 170 peer-reviewed publications, two chapters in prestigious books, multiple international fellowships, and prestigious research grants, as well as local, national, and international awards for excellence, Professor Adisa has demonstrated academic leadership and established impactful research collaborations. Distinguished ladies and gentlemen, I present to you Professor Adewale Adisa as he delivers his inaugural lecture titled Minimal Access Surgery, Narrow is the Way. Thank you.
The Vice Chancellor, esteemed Deputy Vice Chancellor's Academic Administration, R&D, the Registrar, Librarian, Bossa, Provost of the College of Health Sciences and Postgraduate College, Deans, distinguished professors, directors of institutes, heads of departments and unit, colleagues, students, guests, distinguished ladies and gentlemen. Reflecting on the boundless grace bestowed by God, Apostle Paul affirmed to the Ephesian church that in fulfillment of divine purpose, God can release a force into our lives that surpasses our highest dreams, our desires, our thoughts, and hopes. As a child, my dream was limited to becoming a doctor who could help the sick recover. Yet today, I stand before you all as a professor of surgery specializing in minimal access surgery. This lecture marks the 402nd inaugural lecture in this great university. Truly, our gracious God exceeds all human expectation, and this lecture today is a testament to the grace of God. My dream of becoming a doctor was born out of tragedy. When I was just 2 years old, my mother died of puerperal sepsis at the Wesley Guild Hospital in Ilesha, shortly after giving birth to my younger sister, who is here today. At age 6, as a primary school pupil, I was again struck by a mysterious illness that left me paralyzed from my waist down. For 8 months, I could not walk, and my family took me from one hospital to another, and from one spiritual home to another. Against all odds, I regained the ability to walk, returned to school, and ranked first in my promotion exam, despite the fact that I missed 2 terms that year. From that time, I continued to visit a pediatrician in Osogbo for monthly follow-up. Dr. Fadansi showed compassion to every patient, showed so much professionalism that I left myself saying that there is no other profession in my life than being a medical doctor. I attended St. James Primary School in Oshogbo, Anglican Commercial Grammar School in Oshogbo. But while I was in secondary school, my late father drove me to the University of Ibadan and drove me to the Sultan Bello Hall and told me he wanted me to study there just as he had. However, I visited one of my teachers here in Obafemi Awolowo University. I was captivated by the university's grandeur, the flowers, the aesthetic buildings. I returned home and told my dad that I decided that my academic journey could only be fulfilled in a beautiful university. That is great Ife for you. I graduated from the College of Health Sciences, had my housemanship here in Ife, had my youth service in Imo State, but following this, I worked for a year at Abake Medical Center in Oshogbo. In April 2003, I joined the Department of Surgery, OAUTHC, as a junior resident. Unexpectedly, I was assigned to assist Dr. Antonio Arigbabu to perform an endoscopic procedure. After the session, Baba Arigbabu called me. He said, I see a bright future for you. You belong in this place. Those words remained with me throughout my career, and even when Baba was on his sickbed before dying, he still recalled that encounter and narrated them to me. My pursuit of a career in academics was divinely arranged. Professor Abiodun Akinpelu of the Lagos State University was courting one of my sisters, and he came to our house when I was a primary school student. Professor Akinpelu was my first mentor in academics. Following that, my first manuscript writing lesson was as a house officer under Professor Erabo in medicine department. It was, however, under Professor Ladejo Lawal, who is here today, that I learned to write as a surgeon. On one occasion, I faced Professor Lawal and said to him that the version of the manuscript I returned to him was the 5th version of his correction. Professor Lawal said, the only way to get a better Lawal is to continue to correct the current version. I was employed as lecturer 1 in December 2008 and became a full professor 1st October 2017. I will be describing my career along the pathway of general surgery, breast cancer, global surgery, and minimal access surgery. I devoted a significant part of my career to the detection and treatment of breast cancer because of the huge burden of the disease among Nigerian women. For several decades, women across Nigeria suffered due to late detection, inaccurate and inadequate diagnosis, and limited treatment options. In 2011, I led my team in our unit to review the record of our patients, which showed that more than half of them presented with metastatic disease. More than a decade later, Dr. Olasende led our team to also do the same review and discovered that most patients are still presenting with stage 3 disease. On a fateful day in year 2007, I made a presentation here in Ife, and after the presentation, a man walked up to me and said his boss would like to meet me. That was my initial interaction with Breast Cancer Association of Nigeria, founded by Mrs. Betty Anyaru Akeredolu, after she survived the disease. That woman organized so many screening programs and sent women to our clinic and committed our funds to OAUTHC to cover the treatment cost of a large number of women. As fate will have it, she later became the first lady of Ondo State, during which she expanded breast cancer screening and sponsorship of treatment for women with breast cancer on her 68th birthday. She made me write a book on the burden of breast cancer in Nigeria, which I read out to a gathering of nearly all the first ladies of states in southwest Nigeria. That exemplary attitude of Her Excellency towards a disease of huge public health concern should be emulated by people of influence in Nigeria to raise awareness and encourage early presentation. Her mantra in all those engagements was, attitude is everything. And I completely agree with her that a change of attitude to this disease is very crucial to improve the ugly picture of breast cancer in Nigeria. Mr. Vice Chancellor, sir, I was invited by the editor of the Lancet Global Health to write a commentary on the findings of a research conducted in 5 sub-Saharan African countries. The authors reported that there is increased mortality with the further distance that patients spend in getting to the hospital. That has implications for Nigeria, where people have to travel from one state to another, and in many instances from one geopolitical zone to another, just to access care. we need to formulate policies that will help in reducing this in Nigeria. The peculiarity of general surgery practice in settings such as ours present numerous opportunities to impact the health of the people. The unmet surgical needs in Nigeria has limited access to surgical services. I'll talk about abdominal wall hernia, which actually means the protrusion of content through a defect, and is one of the most prevalent general surgery conditions in our country and still constitutes a major burden. My amiable and much respected teacher, Professor Augustine Agbakuru, devoted a huge part of his career to studying and treating abdominal wall hernia in our hospital and in the community, and he recruited all of us into doing that. Gastrointestinal malignancies are diverse in location, peculiarities, and their treatment. In particular, colorectal cancers are a huge burden in Nigeria. A much cited publication from our unit highlighted the disparities in cancer presentation between high and low developing countries. We compared the pattern of their presentation between Nigeria and the United States of America. Nigerian patients were younger, presented with a later stage of disease, and the overall survival, even though stratified by age and stage of presentation, showed a worse prognosis for patients in Nigeria compared to the United States. In Nigeria, gastric cancer, that is cancer arising from the stomach, is the 10th most common malignancy, but its frequency betrays its potency as a killer. I constantly remind our medical students that from ages past, gastric cancer has remained one of the captains of the men of death. In a recent review in our unit, we observed that nearly all presented late with advanced cancers, and we could only across the world. Acute appendicitis has also attracted our attention in practice and in research. It is apparent that too many appendectomies are performed when they are not necessary, and when necessary, paradoxically, too few are performed. A popular African adage says, if you want to go fast, go alone. If you want to go far, go together. The popular Zulu terminology Ubuntu is frequently translated, I am because we are. And this largely describes the societal interconnectedness. The pride of the African community, home and abroad, is the togetherness of our communal living, working together, building relationships that transcend generation. Several decades of scientific research have seen individuals and institutions excel in telling their own stories and professing their own activities. However, in the health sciences, individuals and institution research will lead to the formulation of nuanced opinions, recommendations, and guidelines that cannot be adopted in other settings due to geographical, sociocultural, and economic factors. The role of collaboration and collaborative research in surgical practice in societies such as ours cannot be overemphasized. I therefore challenge our university that we must provide incentives to attract and promote collaborative research. A quintessential example of collaborative research in surgical practice is the Global Surge Collaborative, coordinated by the NIHR GSU unit at the University of Birmingham and the University of Edinburgh in the United Kingdom. Today, more than 5,000 clinicians are working together in surgical research across 100 countries in 7 hub countries. Professor Adesoji Ademuyiwa, who is here today, of the Department of Surgery, University of Lagos, is the director of the Nigerian hub of the collaborative. He has worked hard as the lead and has attracted several research opportunities, funding, and infrastructure to the Nigerian hub, which has grown from a few centers at the inception to more than 50 hospitals today. It was he who invited me to serve as his deputy in 2016, and I remain grateful to him for the opportunity to contribute to the transformation of surgical research in Nigeria over the past few years. Today, the Global Surge Collaborative has initiated numerous practice-defining studies. Global Surge 1 prospectively observed mortality in 58 countries. Global Surge 2 observed the incidence of surgical site infection in patients undergoing abdominal operations across the world. But during the COVID-19 pandemic, the collaborative expanded rapidly to conduct studies on surgical practice and outcome during the pandemic. In the year 2020, that collaborative conducted a survey that included more than 130,000 patients recruited in 1 month. And this was done by more than 15,000 surgeons. That was awarded the Guinness World Record for the most authors in a scientific publication in 2020. The Falcon trial recruited 5,800 patients from 7 countries, and our team here in Ife contributed about 11% of the total recruitment to that study. The Chitra trial was a cluster randomized intervention that investigated the influence of changing your gloves and changing your instrument before you close abdominal incisions. Following robust advocacy by the Professor Adewale-led NIH Nigerian Hub, the Federal Ministry of Health in Nigeria adopted this intervention and mandated its inclusion in the WHO surgical safety checklist to be used in each hospital in Nigeria. The GECKO study collected data of more than 50,000 patients undergoing cholecystectomy worldwide. There are several ongoing studies which include penguin, alligator, giraffe, tiger. We have a zoo for you, just to mention a few. A notable impact of the collaborative is the community engagement initiative, through which surgeons now are going into the community to disseminate research. That initiative in Ife here is led by Dr. Fumilola Wuraola Ajayi of our institution, and I'm very proud of our achievement. The Association of Surgeons, still talking about collaborative research, the Association of Surgeons of Nigeria, under Professor Soji Ademuyiwa in 2023, commissioned a Nigerian collaborative where Nigerian surgeons came together in 2024 to conduct an observational study on surgical site infection in Nigeria. That study was delivered by 320 surgeons and trainees in Nigeria, and we recruited nearly 2,500 patients in just 3 months from 53 hospitals across 32 states of Nigeria and the Federal Capital Territory. Mr. Vice Chancellor, sir, I served as the national lead for that study, which is currently undergoing a review towards publication in a high-impact international journal. It is therefore curious to me that even now, after all this, some people still wrongly define collaborative research as one in which some foreign partner dictates some things and hand it over to people in low-middle-income countries. Some even teach that every collaboration has an underlying mischievous intent of the funder. That is not strange based on the opacity with which academic research was conducted in the past. Today, however, particularly in surgical field, collaborative research is the only way forward by which we can deliver reliable scientific evidence. While conducting these international collaborative studies, we initiated and inserted undergraduate medical students of OAU into research at different levels. At least 18 medical students of our universities have been named as co-authors in journals including British Journal of Surgery and The Lancet. Mr. Vice Chancellor, sir, it is a great feeling of fulfillment seeing these exceptional students making us proud on the international stage at these early stages of their career. More importantly, in the past few years, we've seen some of them graduate from our university and go on to compete at levels which we did not imagine. In a number of our global surgery studies, I've had the privilege of being the Nigerian national lead for research conducted in more than 100 countries. All of us had equal stakes in those research. This brings to the fore the shortfall of the ranking of authorship in publication that is currently used in the appointment and promotion committee of our university. I believe our university must go on to adopt criteria for written research, which will include the citation of the research, the impact of the research, the number of downloads, how it affects current practice, and how it defines future research. Mr. Vice Chancellor, sir, so far, I have described to you my surgical practice based on what I was taught and the surgical disease prevalent in our environment. There is, however, an aspect of my practice that has evolved through my passion to offer Nigerian patients equitable surgical care, such that a patient in Ile-Ife will get the quality and similarity of surgical care that is offered anywhere in the world. That aspect is minimal access surgery. Apart from the discovery and use of anesthesia for pain control during surgical operation, the greatest revolution in surgical care to date is the development of MES technique. While conventional operation means that we cut open the abdomen of a patient, for instance, so that the surgeon can put his hand inside and do the operation. Minimal access surgery, which is commonly referred to as keyhole or minimally invasive endoscopic surgery, relies on not just making a little nick and putting in a telescope and putting in fine instruments and performing the same quality of operation. Personally, I prefer the term minimal access as it more accurately reflects that the key distinction lies in the method of access and not the extent of the intervention. There are a few other beautiful aspects of it. Single incision laparoscopic surgery means that all the instruments are introduced through only one opening in the abdomen. That usually requires equipment that can angulate. There is another type that is called natural orifice transluminal endoscopic surgery, which involve the use of flexible endoscope that are adapted with working instruments. So that will have to pass through the mouth of the patient or through the vagina of the patient. And the same operation can be done without any scar on the patient. If we look at the evolution of what has happened with thyroidectomy, removal of goiter from the neck, the advancement has shown from opening up the neck of the patient to using MAS through the areola of the nipple, to using MAS through the armpit of the patient. And today, goiters can be removed through the mouth of the patient, and the patient has no scar at all to show for it. By the year 2000, robotic and computer-aided systems were produced, and this led to greater precision with which surgeons can do a lot more, even beyond the limitation of the human. Mr. Vice Chancellor, sir, in the Gospel according to St. Matthew chapter 7, verse 14, the Lord Jesus Christ, in describing the only way of salvation and eternal life, made the categorical statement, narrow is the way and difficult is the way, which leads to life, and there are few who find it. In that sentence, Christ was very emphatic about the uniqueness, the challenges, and the joyous outcome of finding and adhering to the only true way of salvation. I can attest to this on a personal basis. From my adventure into the field of MAS, the challenges encountered, I have drawn inspiration from the narrow gate, the difficult way, the life, and only few that they are in. And I will say this in the rest of this lecture. MAS offers several advantages over conventional open operation. This includes reduced trauma to the body due to the fine instruments that are used, less pain and discomfort, shorter recovery time. If there is less pain, there will be shorter hospital stay. The infection will be lower, reduced blood loss, minimal scarring, improved precision, better cosmetic outcome, and lower risk of complication. These advantages have led to the widespread adoption of MAS across the world. Indeed, the narrow way of doing operation, that is, the use of minimal access, is the gateway that leads to improvement of the surgical outcome and better quality of life of surgical patients. Unfortunately, in our environment, there are many barriers to the adoption of MAS in Nigeria. The initial cost of acquiring the laparoscopic tower is high. There is also need for training and retraining of surgeons and the surgical team. The mere fact that you cannot even see inside by yourself means that you depend on image generation, means that you constantly rely on constant power supply. 2 decades ago, when I started trying this, power supply was a problem in Nigeria. But today, it is a greater problem, very sadly. The supply chain has equally been a challenge, with many of the manufacturers having no dedicated suppliers in Nigeria. In 2005, as a senior registrar, I was on the path to the fellowship of West African College of Surgeons by training, but I elected to also do a dissertation for the National Postgraduate Medical College of Nigeria. I held discussion with my mentor, Professor Olusoye Adejuigbe, who then directed me to Professor Oladejo Lawal. Both of these great teachers eventually supervised my dissertation, and that very simple randomized control trial that I carried out was later cited by the WHO expert panel that developed guidelines for the prevention of SSI across the world. I remain grateful to my supervisors for their mentorship, and that very simple project which they supervised set me on the path to a successful career in surgical research locally and globally. Mr. Vice Chancellor, sir, for an ambitious young surgeon who desires to try something new and impact surgical practice in Nigeria, I think the Department of Surgery of this great university is perhaps the best for incubating brilliant surgical ideas. Our teachers of the past pioneered on common services in the department: separation of Siamese twins, neurosurgery, kidney transplantation, cochlear implantation. However, the pioneering role of Professor Anthony Arigbabo in diagnostic and therapeutic GI endoscopy in Nigeria is the tall foundation upon which our subsequent modest achievement in laparoscopy today stands. While undergoing junior residency rotation, I was also greatly inspired by the doggedness of one of my teachers and current Dean of the Faculty of Clinical Sciences, Professor Ayo Salako, who used various locally fabricated materials and equipment to facilitate the establishment of endoscopy in urology practice in our hospital. In 2007, I traveled out of Nigeria for the first of my several stints of training abroad. I returned home and I was stuck with the reality that we don't have the equipment. Then I started tearing through the theater storerooms and stumbled on carbon dioxide insufflator that was purchased in 1982 but has never been opened. It was such an old one that it didn't use electricity. Somebody needs to stand beside it and be pumping the gas to go through. I repaired one light source, and then I approached Professor Adewale, who were able to buy a single chip camera from India. With that, as a senior registrar, I performed the first diagnostic laparoscopy in January 2008. My consultants in general surgery were so supportive of that achievement that within a few weeks, they recruited several patients for me. This enabled us to build infrastructure and experience over time. Unfortunately, our hospital had no board of management back then, and the CMD, even though he was very enthusiastic, could not spend because of the limitation. That limitation inspired us to begin to innovate through local adaptation and improvisation. I supervised a roadside welder to fabricate a laparoscopic tower. We purchased a cheap insufflator, and then we decided that we are ready to go. With that setup, we consistently performed therapeutic and diagnostic laparoscopy. In 2010, after I performed 70 cases, I went to Sheba Medical Center, the largest hospital in the Middle East, for training in advanced laparoscopy. Mr. Vice Chancellor, sir, when I started, I only desired to demonstrate that we can do this in Nigeria, but to the glory of God. I performed that diagnostic laparoscopy in 2008, January. By June, we did a laparoscopic appendectomy. In 2009, we performed laparoscopic cholecystectomy for the first time. We performed first laparoscopic hernia repair in 2011, laparoscopic colon cancer resection in 2011, laparoscopic distal pancreatectomy, and lots more. We have used laparoscopy to treat other conditions such as achalasia, hiatus hernia, and ventral hernia. Today, we have successfully carried out more than 1,400 laparoscopic procedures in the general surgery unit alone, besides the hundreds we have performed with other colleagues in OAU THC. I have been involved also in assisting 6 teaching hospitals to set up laparoscopic services across Nigeria. I am grateful to God. In most instances, our experience with laparoscopic services was the first of its kind in a public hospital in Nigeria. We therefore painstakingly documented our patient outcome and published in scientific journals. But to see the advantage among Nigerian patients, we studied the trend in laparoscopic cholecystectomy. And over a 10-year period, we saw that the number of patients undergoing that procedure in our hospital rose from 7 to 31 within 10 years. The number of days that patients stay in the hospital reduced from 5.2 days in 2005 to 1.8 days in 2015, and today 99% of them stay only a day after the operation. Indeed, narrow is the way the narrow gate leads to life. For a technique initially touted to be mainly for cosmesis, one complication of laparoscopy was an optimal concern. We therefore described the wound complications compared to 25% infection rate that normally happen when operation is done open. Our own patients had infection only in 4.7%, and most of the other complications were very little. My teachers, Professor Sonyade Juigbe and Dayo Showande, ensured that we also developed MAS in the pediatric surgery unit. By 2015, Professor Talabi and I had published a study describing laparoscopy carried out in children and demonstrating that it's also safe and feasible in treating surgical disease in children. Professor Adewale later brought his senior registrar, Dr. Adewale Adisa, to me with the mandate, you must make a laparoscopic pediatric surgeon out of this young man. The young man also encouraged me by taking up the challenge and perfecting the skills. He is one of my most successful trainees and has gone on to do great exploits in pediatric laparoscopic surgery in Nigeria. I'm equally proud of the achievements of his colleagues, Dr. Collins Aduma and Dr. Ibukun Ogundele, who constituted the first generation of laparoscopic pediatric surgeons trained in our unit, and they've gone on to train many others. As our profile improved, we began to initiate and participate in local and international collaborative studies on minimal access surgery. In collaboration with an Italian research group, we participated in an RCT to evaluate the efficiency of drain in preventing postoperative abdominal collection. In that study, we recruited more than 25% of the total population from Ile-Ife. That study, carried out in 2011, opened up our unit to further international collaborations. We also developed collaboration with our local colleagues in conjunction with our ophthalmologists led by Professor Mrs. Oluwatoyin Onakboya. We carried out a prospective case control observational study on intraocular pressure changes in patients undergoing elective laparoscopic operation requiring either a tilting of head up or a tilting of head down. And we found that laparoscopy was very safe in them. Being a disease predominant in the black population, the inflammatory changes in sickle cell anemia has not been studied extensively by the Caucasians. And inspired by the passion of Professor Mrs. Nora Akinola for the welfare of sickle cell patients who are particularly prone to developing gallstones and requiring laparoscopic cholecystectomy, we carried out a study in conjunction with hematologists and chemical pathologists. That exploratory study demonstrated that MAS strategies for sickle cell patients may help to mitigate their enhanced inflammatory response to trauma. Mr. Vice Chancellor, sir, that study was carried out through a grant from the Obafemi Awolowo University Research Committee, and I'd like to appreciate the university for this. We carried out a feasibility study on the management of pain following laparoscopic surgeries. In conjunction with our colleagues in the anesthesia department, we conducted a placebo-controlled patient and outcome assessor blinded external feasibility RCT on patients undergoing elective lap chole for symptomatic ultrasound-proven gallstone. Sadly, many people still view laparoscopic surgery as a luxury meant for those who can afford it. In Nigeria today, many public and private hospitals attach prices to laparoscopic procedure that make it beyond the reach of the average Nigerian. Some hospitals perform only a handful a year due to the high cost to the patient. Over time, the National Health Insurance Authority also removed laparoscopy from procedures covered by the scheme. That particular ill-advised decision ensured that hospitals and patients would rather prefer to do open rather than laparoscopy. We carried out a prospective study of patients undergoing open or laparoscopic appendectomy in Ile-Ife, Lagos, and Owerri in the study that we call Lion Study, and performed a first-of-its-kind health economic analysis of the two procedures in West Africa. The MAS approach has a higher cost, but was associated with a lower societal cost, a lower infection rate, and a faster return to work, meaning that all the benefits are for the patients. The finding of this prospective national study corroborate those of a study carried out earlier by a postgraduate fellow, Dr. Kate Smiley, who visited us from Salt Lake City and carried out similar study in our patients. I therefore appeal to all healthcare policymakers in Nigeria to prioritize minimal access surgery as a policy. On the other hand, I have frequently quoted the sayings of Dr. Ray Price and Dr. Paul Sevenson, who says it is more important for a poor person to have laparoscopy than a rich person. Today, many affluent Nigerians will travel abroad for medical tourism, build fun and vacation into receiving care for some common ailments that can even be treated locally. But a poor person, who may equally be the breadwinner of the family and often self-employed, will undergo an open operation and as a prolonged length of hospital stay, delayed return to normal activity, cannot return to work on time, with catastrophic expenditure from out-of-pocket payment. In many instances, families have undergone untold hardship just by undergoing such open operation. If our society can ensure that the poor can equitably access MAS and get the benefit of shorter hospital stay and early return to work, we will be reducing poverty among our patients. Along with Dr. Ray Price from the USA, I had the privilege of co-authoring a chapter on challenges and solutions to performing MAS in underdeveloped settings. We identified the strategies adopted by the government of Mongolia, a country poorer than Nigeria at that time, to adopt MAS as a public health policy and as a major solution to improve access and minimize the gains of the technique for the benefit of the people in their own country. Mr. Vice Chancellor, sir, before starting my journey with MAS in Nigeria, I could only make deductions from around the world regarding the advantages of MAS. However, with the experience of more than 1,400 patients, and having carried out several studies among Nigerian patients, I return to you today like King Solomon, author of many great biblical proverbs, to say, narrow is the narrow way of operation, using minimal access incision, is the way that leads to improved outcomes and better quality of life for Nigerian surgical patients. Having acknowledged the unflinching support of all my professors and all consultant surgeons, I want to place on record the extensive support of our nurses in this success story. We have excellent perioperative nurses who not only started with us when the journey was rough, but they also grew with us by maintaining our equipment and training junior nurses along the way. On the surgical wards, our nurses professionally cared for our patients to ensure that we have success. I'm immensely grateful to all our nurses. My colleagues and our surgical residents have also played very important role. Our patients, they believed in us, even when we informed them of our initial struggles with equipment. But many of our patients even encouraged us not only to succeed, but to continue to strive to do more. On a fateful day in August 2011, I was on my routine clinical duties when I was summoned by the then CMD, Professor Olusoye Adewale, to meet with the management of the hospital. It turned out that Professor Onyebuchi Chukwu, an orthopedic surgeon, who was then the Honorable Minister of Health, came on an inspection visit to OAU THC. He cited our improvised laparoscopic tower and register of operation, which showed that we had performed about 200 cases without publicizing it up to Abuja. A few moments later, I was in front of journalists receiving a ministerial award for excellence. Following that, the management board of OAU THC, headed by Professor Oluwole Akonde, gave me a merit award. Both Emeritus Professor Akonde and Professor Onyebuchi Chukwu continue to encourage and monitor my career progress on a personal note for several years, even after they have left their respective offices, and both of them are virtually participating in this lecture today. On the international stage, I had the opportunity to share our humble experience at different surgical fora. In April 2012, I submitted an abstract titled Local Adaptation and Improvisation for Laparoscopy in Nigeria, just to share our experience, but it was selected to be presented in a special session titled Stories of Sages Heroes. I was later selected as a Sages Ambassador representing Nigeria at the 2018 meeting of the Society in Seattle, Washington, where I was invited to speak again to the Society. Our unit has also hosted residents and fellows from within and outside Nigeria for training and all research collaboration. Mr. Vice Chancellor, sir, for the past 15 years, we have been in the vanguard of providing laparoscopic surgeries at affordable rates to Nigerian patients. We could only do this because we continue to get donations from abroad. Of note is Medwish Incorporated in Cleveland, from which OAU THC has received 4 pallets of consumables on 4 different occasions. Secondly, I'd like to mention Mr. Segun Komalafe, a British colorectal surgeon of Nigerian descent, who has not only repeatedly sent equipment and consumables to us in Ife, but has visited Ife several times to facilitate training. With the support of Professor Victor Adewale as CMD, we hosted many local and international guests and organized masterclass sessions in laparoscopy and advanced GI techniques, attracting participants from all geopolitical zones in Nigeria. Few are daring. Globally, general surgery training now places premium on competency as against the length of training and the log of procedure. The practice of MES, perhaps more than any other subspecialization, bring to the fore the need for skill training and retraining, as well as competency assessment to transition from training to practice. In my pioneering role with MES, finding capable assistants for operative procedure became a huge challenge and a potential obstacle to performing advanced procedures. This realization led me to spearhead the establishment of a surgical skills laboratory in the Department of Surgery in 2012. For over a decade, that laboratory has facilitated skill acquisition for consultant, residents, and medical students. We published the first journal article in Nigeria that described the introduction of basic surgical skills to undergraduate students. We have described the development and use of locally fabricated suturing parts to train undergraduate medical students in basic suturing skills. I wish to appreciate Dr. Adewale Adisa for sustaining this training for our medical students over the years. Our laboratory collaborated with Professor Fadeke Ogini of the Oral and Maxillofacial Surgery Department of this university and an Italian colleague in the USA to describe the use of affordable lap camera system for training. Across Nigeria, I've also had the privilege of facilitating training in laparoscopic surgery in several teaching hospitals. In 2016, under the leadership of Dr. Jimmy Coker, who is surprisingly present here today, and with the huge support and mentorship of Professor Chris Bode, who is also surprisingly present here today, who was then the Chief Medical Director of Lagos University Teaching Hospital. We established the Laparoscopic Surgery Society of Nigeria as an umbrella body for those practicing laparoscopic surgery in Nigeria. LASSON has contributed immensely to the delivery of training to surgical residents across Nigeria. During the COVID-19 pandemic, the Education Committee of LASSON, led by me, provided leadership in publishing recommendations for the safe practice of mass in Nigeria. On the international scene, I've been a facilitator at several laparoscopic training programs organized by the West African College of Surgeons across West Africa. I was the co-lead of the team that developed the curriculum for laparoscopic training in Africa for Medtronic. In 2016, I was awarded the International Scholarship for Surgical Education by the American College of Surgeons. That scholarship granted me the unique opportunity of being hosted by front-leading surgical educators in Indiana. Through that linkage, I became a member of the Association for Surgical Education, and I've served as the representative of Africa on the International Task Force since 2018 till date. In May this year, I was invited as faculty to the 2025 annual meeting of the association to speak on the Nigerian experience of using simulator to train in low middle income countries. At the recommendation of Dr. Jimmy Coker, I have also served as an expert for training in advanced laparoscopy skills at ICAD Africa in Kigali, Rwanda since 2003, in which I volunteered to train surgeons and trainees from across Africa and the Middle East in the laparoscopic surgery. We have made efforts to improve the training of trainers in the form of consultants who would then train residents and populate the field that be therein. We have also successfully trained residents whom we are proud to see improving the practice of MES across Nigeria. At least 52 residents from across Nigeria have been successfully trained in laparoscopy in our unit. Of these, 11 of them who are now consultants are practicing in different hospitals across Nigeria, while many of them have relocated outside Nigeria. 18 consultants have also attended training or undergone attachment in our unit. In OAUTHC, I started alone. But today, we now have 4 consultants independently performing laparoscopy. Today, at least 5 senior registrars routinely perform emergency laparoscopic appendectomy in general surgery and pediatric surgery units. We have certainly evolved, we are still evolving, and we give all the glory to God. The success of our training has, however, been significantly eroded by the unbridled migration of trained medical experts in what is called JAPA syndrome. We need to remember that it is mind-blowing that successive state and federal government have continued to neglect the resultant manpower shortages from the JAPA syndrome. On our part, we attempted to migrate that disruption caused by this by constantly training more residents. We got lucky in 2022 when we were contacted to make OAU a lead site for the training of Welcome Lip-Safe project in laparoscopic surgery. That project, titled Camels and Camels Plus, has enabled us to facilitate the acquisition of basic surgical skills by 100 medical students and more than 20 surgical trainees. This is an incredible opportunity, judging by the fact that my own generation needed to travel outside Nigeria to see this, but now OAU medical undergraduates are able to get trained even with AI-powered laparoscopic tools. Mr. Vice Chancellor, sir, as the national lead for that study and one of the assessors of the trainees online video, I can confidently attest that some of our medical students rank among the best globally, not only in skills acquisition, but also in how rapidly they progress along the learning curve. It therefore leaves us with the responsibility of expanding opportunity and improving facilities to train our students. Green surgery. The concept of green surgery demands surgical practice that aim to minimize environmental harm while maintaining the highest possible standard of our patient care. We are encouraged to build sustainability into our surgical practice by adopting technique and innovation that encompass a triad: good clinical outcome, reduce cost, but also reduce waste generation from operation. We are currently working with the perioperative nursing staff of our hospital and the environmental health department to collect plastic and metal waste from our operating theater. That will be used to create a green surgery park in phase 2 of OAU THC. We are seeking renewable, affordable, clean, and sustainable energy solutions for our operations. Through the research collaboration we have built over the years, our hospital has been selected as a pilot site for the Green Energy Initiative of NIHR GSU, seeking to deploy solar energy to power theaters and LMICs. I believe our main theater and intensive care unit will soon enjoy this facility of free solar panels. On the international scene, at the invitation of my very good friend, Professor Anil Bangu of the University of Birmingham, I participated twice at the Greener Surgery Conference, where topical issues in this emerging field are discussed, practical solutions are shared, and potential barriers identified. Future trend in minimal access surgery. The past 2 decades have demonstrated that the way forward is the deployment of MES techniques in all aspects of surgical care. The advantage demonstrated in the narrow way, initially limited to abdominal operation, are now vastly replicated in nearly all surgical specialties and procedures. The use of robots in MES has come to stay. In the recent past, smaller African countries such as Angola and Rwanda have been embracing robotic surgery with their government providing incentive for equipment and training. The challenge is that when cheaper robots from Asia become available in a couple of years, Nigeria will need to play catch up with the rest of the sub-region. In my opinion, we need to urgently acquire facilities and embrace training in robotic surgery. We're already way behind the rest of the world. We are certainly witnessing the incorporation of artificial intelligence into surgery, and I believe this will define the future. Real-time imaging for surgical intervention is also being developed, and we have facilitated the introduction of enhanced sensors for post-operative patient monitoring at OAU THC, where wearable sensors are being placed on patients, and the surgical team can remotely access, review, and make decisions. Closing reflections. Mr. Vice Chancellor, sir, over the course of my academic journey so far, I have found immense fulfillment in teaching and mentoring undergraduate and postgraduate students of outstanding caliber. To date, I have successfully supervised 18 postgraduate dissertations, 12 of them in the West African College of Surgeons and the National Postgraduate Medical College. One of them obtained a fellowship in global surgery from the University of Utah, and another one earned a master's degree with distinction from the University of Edinburgh, UK. Presently, I'm guiding 5 candidates through their fellowship examination. I'm supervising 3 PhD candidates across Nigerian universities, and I'm co-supervising a PhD candidate at the University of Birmingham, UK. I have served as an examiner for the Part 1 and 2 fellowship exams of the National Postgraduate Medical College of Nigeria, and being on the team of the college to accredit tertiary hospitals across Nigeria. I have also contributed as an external examiner at the final examination for 5 medical schools across Nigeria. In 2018, I served as a member of the Federal Ministry of Health Technical Expert Group that developed guidelines for the management of pain in Nigeria. In addition, I've served as a peer reviewer for several esteemed journals, and I had the privilege of reviewing promotion cases to the professorial cadre for universities in Nigeria and outside Nigeria. To God be the glory. Mr. Vice Chancellor, sir, I have described how we have navigated the difficult way to establish the narrow way of operation. We have observed that this narrow way leads to improved quality of life for our patients. And this has motivated us to increase the few that be found therein. As I bring this lecture to a close, I wish to remind us of the following. Minimal access surgery has demonstrated superior outcome for Nigerian patients. It should therefore be integrated into the national policy as a cornerstone for addressing the country's surgical healthcare needs. Although the initial cost of MES infrastructure is high, the long-term benefit translates to significant economic gain that far outweighs the startup expenses. Laparoscopic surgery yields greater benefit for the poor than the wealthy. There must be a national commitment to ensuring equity in healthcare delivery, especially for our vulnerable populations. Continuous training and capacity building across the entire surgical ecosystem must be prioritized to safeguard the health of both current and future generations. The future of surgery is being shaped by modern technology and artificial intelligence. Nigeria must act decisively by strategic healthcare investment to close the digital and infrastructure divide and reduce medical terrorism. The unchecked migration of skilled young healthcare professionals is eroding several decades of surgical innovation and threatening the survival of Nigerian public health system. While talent may leave, let's all remember that over 220 million Nigerians remain, most of whom still lack access to quality care. This reality demands urgent and strategic action. I would like to deeply acknowledge the immense impact of my many mentors in general surgery. Professor Sarigbabu, Adeyemo, Adejuyigbe, Professor Akinola, who is present here today, Professor Lawal, present here today, Professor Adesukomi of blessed memory, Professor Agbakuru, and Dr. Akinkole served as the foundational pillars of our training, and it was truly a privilege for me to learn under their guidance. The late Dr. Adewale was also my teacher, who left the scene early, but he made a great impact within a short time. I also extend my sincere appreciation to all the professors in the Department of Surgery, the Faculty of Clinical Sciences, and the College of Health Sciences at this esteemed university. Their dedication shaped my journey as both a student and faculty member. It has been equally rewarding to contribute to the growth of junior colleagues and humbling in return to learn from them. I am profoundly grateful to my friends at the NIHR GSU, at the University of Birmingham and University of Edinburgh. I appreciate all the leads of the 7 hub countries, Professor Ademuyiwa, who is present here today, the director of the Nigerian hub, my co-deputy directors, the dedicated staff of the Nigerian hub for their collaboration and their support. Professor Chris Bode has not ceased to amaze me with his constant encouragement, while Dr. Jimmy Coker speaks highly of me everywhere across this continent. My heartfelt appreciation goes to the leadership and members of the New Covenant Church Ife City Center, where I have the honor of serving as the satellite pastor. The unwavering love and support from the congregation have been a continuous source of encouragement. The pastoral team of that church has all been instrumental in my personal life and in my spiritual journey. I'm especially grateful to Reverend and Mrs. Paul Jinodu, Baba Jao, the Oyelades, Reverend and Professor Mrs. Shoeton, the Ogunfowokons, all the conference pastors, as well as all the pastors of the Ile-Ife conference. I give special thanks to God for Reverend Dr. and Dr. Mrs. Francis Olonode, whose spiritual mentorship has enriched my walk with the Lord. I remember my late father, Chief Solomon Adewale Adisa, with deep affection. Though he yearned to witness this academic milestone in my life, he departed nearly 5 years ago, leaving behind cherished memories and a legacy of compassion and community service. I'm also grateful for the love and support of my sisters who are all here today, their families, my father-in-law who is present here today, and my extended family, many of whom are also present here today. While I have spoken so far of the grace of God in my professional journey, the most profound physical expression of that grace in my life is my wife of nearly 23 years, Olubukanla Oluyomi Adisa. She has been a God-given source of peace and strength, helping me to better understand the beauty of covenant relationship. I will not be here today without her sacrifices for me. Our children, Oluwadarasimi Joy and John Oluwatobiloba, continue to be incredible blessings and constant sources of inspiration. I am blessed. Now to the King eternal, immortal, invisible, the only wise God, be honor and praise now and forevermore. Thank you.
I present this certificate of presentation of inaugural lecture to Adewale Adisa, a professor of surgery in the Department of Surgery, Faculty of Clinical Sciences, College of Health Sciences, Obafemi Awolowo University, Ile-Ife, Nigeria, who had delivered the 402nd inaugural lecture titled Minimal Access Surgery, Narrow is the Way, on July 22nd, 2025. Congratulations.
If it had not been for your mercy, yeah. Say, I'm shining glory. Let's go. For your grace, or a fashion memorial. If it had not been for your mercy, I know shining memorial. And you say, if it had not been for your grace, or a fashion memorial. If it had not been for your mercy, I know shining morning. Say it again, say, if it had not been for your grace, for your fashion morning. If it had not been for your mercy, if it had not been for your mercy, your